professor of clinical pathology at the University of Southern California. After earning a bachelor's degree in anthropology from New York University, she trained in anatomic and neuropathology at the University of California, San Francisco, where she worked with Dr. Eric Wang on the study of the human fetal ganglionic eminences and their contribution to the interneuron population of the mature brain. Since 2016, she has worked at Children's Hospital Los Angeles, where she serves as the director for the Center for Pathology Research Services and the pathology directors for the CHLA Brain Tumor Center. I will now turn it over to Dr. Cotter.
Thank you so much. Hi, everyone. Thank you for coming today. If I can get this to go. So I have no disclosures. Today's learning objectives were already circulated, I think, and they're shown again here. We'll review workup and diagnosis of epilepsy. We'll talk about some histologically defined entities that cause epilepsy and might be seen in routine neuropathology practice. And then at the end, we'll take a short time to go over some considerations for handling tissue when these cases do come to you. So we'll start with some background and clinical context for epilepsy, and I'll spend a fair amount of time covering this because I think it helps us participate in the care team a little more fully. And then we'll look at some examples of different epilepsy-associated pathologies. And then lastly, those kind of practical tips for these cases as they come through. So epilepsy is defined as a presence of recurring and unprovoked seizures. And this excerpt is from the clinical definition of epilepsy. So these seizures should be at least 2 in number. They should be more than a day apart. But alternately, a single unprovoked seizure can qualify if it's judged from other clinical contexts that the probability that seizures will recur is judged to be over 60% over the ensuing 10 years. Or if a patient has a clinically defined seizure syndrome, even one seizure can be enough. So this is an estimate of the prevalence. So we think about 1.2% of the US population have active epilepsy. And while the onset can, of course, occur at any age, it tends to crop up in early childhood and in patients over 55 years of age. So I think it's important to emphasize the prevalence of epilepsy. This works out to meaning that 1 in 26 people will develop epilepsy at some point in their life. And that means this diagnosis is more common than several of the diseases that we talk about often in neuropathology, things like multiple sclerosis, muscular dystrophy, cerebral palsy, and Parkinson's, all combined are less common than epilepsy. And the impacts of this are wide-ranging because this often affects pediatric patients. We also think about the effects on their family. And even patients with very well-controlled epilepsy who are seizure-free still report decreased quality of life due to the stress and uncertainty of when another seizure might come. So for us in neuropathology, an important clinical element to understand is the meaning of drug-resistant epilepsy. So these are the patients from whom a subset will make their way all the way to epilepsy surgery, and thus are the touch point with neuropathology. So if 65 or 70% of patients are going to respond to the first or the second anti-epileptic drug that's used, that still leaves about 1/3 of patients who are going to fail both of those drugs. And of those drug-resistant patients, there is actually less than a 10% chance, and in some studies, as low as a 4 or 5% chance that they will respond to a third medication. And so this is termed clinically medication-resistant or drug-resistant epilepsy. So in the diagram here, you can see this is depicted as an inverted pyramid, where this review article studied the gaps in and the issues with getting patients appropriately referred to epilepsy centers or to surgery or to vagal nerve stimulator placement at the very bottom of the pyramid. But you can see there's a really significant fraction of epilepsy patients who do meet criteria for drug-resistant epilepsy. And this is really the patient population that we will generally encounter in neuropathology. So I work in a children's hospital, and so a lot of what I talk about has a slant towards the pediatric. But I think it's important for us to recognize the urgency of working up kids for epilepsy in a timely manner, and to understand from our seat in pathology why that urgency is there. So for kids, there's so much neurological development happening in those first years of life that there's this idea that there's a window of opportunity that exists for them to acquire basic skills of life. And that window can be missed when they're very sick. So you can see in the graph here, the percent of patients with an IQ less than 80 and kids with an epilepsy onset before 5 years of age appear to be really differentially impacted compared to their older pediatric counterparts. So it's also important to recognize that the ongoing duration of epilepsy has a strong association with worse psychosocial outcomes, and things like self-aggression or attention issues are noticed in these populations. So understanding that urgency, particularly in the pediatric setting, I thought it would be helpful that we kind of walk through the process of working up a patient with epilepsy. So for those of you who attend your hospital epilepsy conferences, a lot of this vocabulary and idea will be familiar. The first goal is to really fit the clinical picture into a particular type of epilepsy, which can be focal, meaning it's coming from one spot in the brain. Generalized means coming from all over, or mixed. And then next is to consider what could be that underlying cause. And that can be something structural. And those are the things I think we tend to think about as neuropathologists. But it could also be something metabolic, genetic, or both. So first things being first, this all starts with a thorough H&P and labs that can involve EEG, MRI, possibly some broad genetic testing. And then patients who have drug-resistant epilepsy should really be seeing an epileptologist for that higher level of evaluation. And that can include video EEG, specialized MRI protocols that are more sensitive for structural alterations, neuropsych testing, possibly whole exome sequencing, and special functional imaging techniques like PET, SPECT, MEG, which really help to localize the epilepsy. So the way in which seizures are classified by neurologists is summarized here. And this is from the ILAE, or the International League Against Epilepsy. And this is a 2017 consensus classification system. So many of you might recognize the terms complex partial or simple partial as referring to the seizures with change in consciousness or no change in consciousness within the focal category. But in the new system, with the new terminology, we can use much clearer terms: focal aware or focal impaired awareness, with either the presence or the absence of motor signs. And remember always that even a focal seizure can secondarily become generalized. So that's something that the epileptologists are going to be looking for as they work up these patients. So for generalized seizures, there's classification as motor or non-motor, and absence seizures fall into the latter category. As for tests to help classify the seizures, video EEG significantly increases the percent of detection of seizures to over 90% in a 24-hour monitoring period. And for patients who turn out to have focal seizures, they definitely do need MRI if they haven't had it done already, because we're thinking about a potential structural alteration underlying that focal epilepsy. So here's just the checklist format of that ILAE classification. So you can see the hierarchy of terms here, with either focal seizures at the top, generalized seizures, or possibly even unknown after further examination. So just a brief word about EEG, because while we don't really need to know how to read EEGs, you may find yourself in meetings where this is discussed. So I just like to review the general concept and some of the things that might occur in terms of activation techniques. So on the right, we have a layout of the EEG grid, so you can have an idea how many probes there are and how they generally map onto the lobes of the brain. It gives you, I think, an idea of the level of resolution or anatomic detail that you might achieve in an EEG study. And so the brain has normal electrical patterns, and these vary throughout different brain activity. So I listed here some of the general patterns that our colleagues can recognize on EEG. Just notice that even something like closing the eyes while remaining fully awake can generate a detectably different pattern of EEG, as will the different phases of sleep. There are some patients with global disabilities who might not have normal EEG patterns at all. And in the EEG process, particularly in the longer studies, sometimes activations will be used in order to induce a seizure. Some of those things include flashing lights, deep breathing, or even sleep deprivation. So as for the seizure itself, let's just review a very simplified version of this. So epileptic seizures happen when there's a burst of neural activity that leads to those physical symptoms we associate with a seizure. And so the basis for seizure onset is really an excitatory overload. So in the picture here, it's shown as the release of synaptic vesicles full of glutamate. That's usually coupled with decreased inhibition and these bursts of excessive neuronal discharge in the brain more diffusely. But this specific diagram is just showing you that one excitatory synapse. And this is from a neurology paper that depicts all of the sites of action of the many anti-epileptic drugs, be that at the level of the presynaptic ion channels or the synaptic vesicles themselves or at the postsynaptic membrane. But to put it simplistically, for our purposes, the seizure is an excitatory overload. But of course, neurons are not alone in the brain, and it's hypothesized that glial cells actually function as a buffer for excess glutamate in the brain. And so in the picture on the left, you have the glial cells on the sides facilitating the movement of glutamate away from the synapse. But it seems that at some tipping point, that buffering capacity gets overcome, and there's generalized hyperexcitation, which is the ictal state, which you see on the right. So when there's overstimulation of the glutamate receptors and prolonged influx of calcium and mobilization of other ions, you can see cell injury or even cell death. And so those are the consequences that we want to try to avoid. So switching gears slightly from seizure mechanism, I want to talk about workup for epilepsy patients and the vocabulary around the phases of evaluation and treatment. Because these are terms we commonly do hear in epilepsy clinical meetings. And so I thought it would be good to just have an idea of what happens when. So in phase 1, I want you to think of this as a non-invasive phase. This includes things we already discussed, like video EEG, neuropsychiatric testing, and marker. And once focal epilepsy is established and there's some discussion about surgery, the patient's going to move to phase 2, which is where consultation with neurosurgery and anesthesiology occur, but also includes placement of intracranial monitoring devices. So those are going to more precisely map out the epilepsy, the focal epilepsy. So some ways this can be performed are shown in the picture. There are what are called grid electrodes. So those are evenly spaced on a little patch that sits on the surface of the brain. There are strip electrodes, which can make more sense depending on the seizures and the pattern seen by extracranial EEG. And then there are depth electrodes, which are sometimes used to probe deeper structures. And all of these will provide data about the seizures and their onset and distribution via electrocorticography. So electrodes matter to us in neuropathology because they cause histologic changes. And where there has been electrode placement, we very commonly will see leptomeningeal inflammation, but also sometimes from deep electrodes, we can even see a linear tract. And this is a figure from an animal experiment, but it shows the similar features that we'll see in our patient samples, which is you can clearly see in the cross section of this gyrus a linear tract extending in from the peel surface. It's positive for isolectin, so that reflects macrophages, and it's missing the appropriate myelin content that should be seen in that part of the white matter, and is rimmed by accentuated GFAP staining. So if you're not expecting to see an electrode tract, it can be very confusing to encounter. And sometimes there's just kind of generally increased cellularity in these regions. You might wonder if you have a low-grade tumor. Sometimes these get a lot of unnecessary immunostains thrown at them. So this is a really important part of the patient's clinical history that you want to be familiar with before you receive the resection sample. So if a patient moves through phase 1 and phase 2, and it's established that there's some focal lesion that could benefit from surgery to intervene, then they move to phase 3, which is the surgical approach. So for us, really only the scenario of resection is going to generate a sample for the neuropathologist. But other patients might have epileptogenic lesions that are thermally ablated or disconnected instead. Phase 4, if you do hear that term, would just refer to the postoperative period. I guess that's when the neuropathologist is doing their part of the patient care as well. Okay, so while epilepsy is a very common neurological condition, it is not in and of itself a diagnosis. Epilepsy can be caused, as you know, by many different conditions affecting the brain, and those range from the structural to tumors to inflammatory lesions. And it just happens to be the case that all of these converge on a phenotype, which is that electrical and clinical manifestation that we see in seizures. So for the next part of the lecture today, we're going to focus on some of the more common causes and more specifically causes that can be diagnosed by us by microscopic evaluation. This table is from a review of neuropathology findings from the European Epilepsy Brain Bank, which was published in 2014. And you can see here that the most common diagnosis among their resection samples was hippocampal sclerosis, which is abbreviated here as HS, at 32.7%. This is followed at 26.5% by low-grade epilepsy-associated tumors, or LEAT, or long-term epilepsy-associated tumors. So that's about a quarter of their cases. And then after that, you have malformations of cortical development, or MCD. So that would include focal cortical dysplasia. And all told, that category accounted for about 16% of their cases. So I also want to point out two things. One, there can be dual pathology. So just because you see one of these doesn't mean there's not a second pathology present. And in 7.7% of their cases, there was no lesion by pathology evaluation. So I figured we'll start with hippocampal sclerosis since it's the most common. It's been recognized for a very long time, and it's the pathologic pattern we see in over half of mesial temporal lobe epilepsy cases. So this is defined by an overall loss of hippocampus volume, and it seems to be very amenable to surgery with good outcomes, which probably accounts for that very high representation you see in the pathology samples in the brain bank. So histologically, what's seen is neuronal loss in the hippocampus, and we'll talk more about the different subfield involvement, as well as some associated histologic features, including granule cell dispersion and axonal reorganization, or mossy fiber sprouting, which we'll also talk a bit more about. So here we have the hippocampus from autopsy in one of the more common orientations we like to have. So cut at the level of the lateral geniculate nucleus. In the picture, you see the relationship of the hippocampus to the rest of the temporal lobe and to the lateral ventricle. And zooming in closer to the hippocampus, we see the dentate gyrus, which is composed of these small neurons closely packed. You see it as this squiggle or stripe. And then starting from the middle of that area, we have Ammon's horn, or cornua monis, which is abbreviated as CA. And that's divided into 4 subfields. So CA4 being the area in the dentate, then CA3 next, then CA2 as we come around the bend, and then lastly CA1, which extends all the way to the subiculum on the temporal lobe. So a lot of work is actively being done to understand the different subfields of the hippocampus, their connectivity, their contributions to things like memory, navigation. For us, I think it's important just to recognize the overall layout here, because the types of hippocampal sclerosis are going to be defined by the presence of lesions within these different subfields. So if we define these subfields as such, you can see that CA1 is actually quite broad at this level. And then in hippocampal sclerosis evaluation, we're going to look for loss of neurons relative to a normal baseline in each of these areas. So there are studies that show that when we try to do this by eye, we can't really reliably detect neuronal loss until it's as much as 30 or 40%, which means that more subtle neuronal loss isn't going to be picked up by eye. And there's been suggestions to use, instead of visual inspection, image analysis, quantification techniques to try to make the detection of neuronal loss more systematic and reproducible. And if quantification is being done, it's suggested that it be done at the center of each of the subfields that are shown. Hippocampal sclerosis by MRI is going to show volume loss of the hippocampus. And while there are some researchers who can segment the specific subfields of the hippocampus, this is not really moved into routine radiology practice. So you, as a pathologist, are not going to know much detail other than that the hippocampus looks sclerotic when the patient's going to surgery. And if you compare in this picture to the contralateral hippocampus, you can see that the left hippocampus is significantly smaller. So you might hear the term mesial temporal lobe sclerosis, or your patient might carry that diagnosis. What that means is that there's more extensive involvement of the structures in this area beyond just the hippocampus, sometimes including the amygdala or the parahipogyrus. So as I alluded to, it has been suggested there are different subtypes of hippocampal sclerosis, and these have clinical significance, including differences in age of onset, better or worse post-surgical prognosis. It seems like the highest rates of seizure freedom after surgery are in patients with classical HS or type 1. And the other types have poor prognosis relative to that. There isn't a known genetic susceptibility to hippocampal sclerosis that I'm aware of. This is from an article about kind of mapping the different lesional distribution in hippocampal sclerosis, and we'll take this apart a little bit on the next slide as well. So here's a summary of what defines the types. You can see that classical hippocampal sclerosis, or type 1, should involve CA1 and CA4 to different extents. And in some forms, there's actually involvement of all the subfields, like this picture here. Type 2 is also known as CA1 predominant, and that can be a little confusing because type 1 also involves CA1. But if you look at the table that I colored in here, what defines type 2 is it's really CA1 that predominates, and the other subfields are either not involved or only minimally involved. Type 3 is CA4 predominant, or encephalitis sclerosis, as it's called sometimes. And then shown here are examples of what's called no hippocampal sclerosis, or gliosis without neuronal loss. So you're not going to see neuronal loss in the sectors of these examples, but you might still have the seizure presentation. So I thought we could look at a couple examples, because this is an area where I think it's easy to get a little confused. And so these are just classical pictures from some of the original publications about this, but I took out the answers. So first, we're going to be looking for neuronal loss. And this is a new end stain, which is really helpful when you're trying to assess neuron distribution. And the question here is, where is a neuronal loss? And so in example A, you can see we have a lack of staining for new N in CA4, and then certainly over in CA1. And so that qualifies as classical hippocampal sclerosis, ILAE type 1. In example C here, you can see there's loss of neurons in CA4, and then the rest of the subfields look relatively okay. That would be CA4 predominant, or ILAE type 3. Next two examples. Here, it's a little difficult to see any neuronal loss in the example on the left, but certainly on the right, we can identify right away that CA1 seems to have a lot of neuronal loss. And then this one, not sure. So this is an example of no hippocampal sclerosis, or gliosis. And this is an example of the true CA1 predominant ILAE type 2 hippocampal sclerosis. So associated findings in hippocampal sclerosis include something that's called granule cell dispersion. And this is pretty common in temporal lobe epilepsy cases, as you can see. It's a bit hard to define since the hippocampus can be cut in different angles, particularly in the surgical specimens where maybe the orientation isn't optimal. But one proposed definition is that there should be over 10 layers of neurons and have ill-defined boundary. And this is thought to be related possibly to neurogenesis that might occur after seizures, or to some differences in migration that might be promoted after seizures. But one of the interesting things about this phenomenon is there's a recent pediatric series that brought this a little bit into question. And so in this series, which is cited at the bottom here, at least in their review, they looked at a number of epilepsy cases compared to control cases, and they found that granule cell dispersion, including kind of the spreading apart of the dentate neurons, more than 10 layers, that this was really not specific to seizure-affected brains. So I think this is a little bit under active discussion at this point, particularly in the pediatric population. So this would be the normal appearance of the dentate gyrus. This is a pattern they referred to as tram track appearance, where you have this splitting look. And this is what's called disaggregated in their series. And they found that these findings were not always associated with seizure-affected brain. So another histologic change that can be seen in hippocampal sclerosis is called mossy fiber sprouting. This refers to outgrowth of axons of the dentate gyrus neuron. So they're shown here with this stain called dynorphin. Dynorphin is an endogenous opioid, and the hypothesis is that the dentate gyrus neurons actually synthesize it in order to control the excitability of the pyramidal neurons. So here you see this increased dynorphin staining around the dentate gyrus, almost like this big dark eyebrow around the whole thing. and they extend out into the molecular layer, where on the crescent violet stain here, you can see the dentate gyrus looking like it usually does. So this is sometimes used as a marker for hippocampal reorganization or change. So I think it's good to be aware of this, but I don't know at this point in time that this has a particular clinical utility in a diagnostic setting as yet. So next I want to move on to focal cortical dysplasia. This is that second most common category to encounter in surgical neuropathology. And these are defined as specimens that have microscopically discernible architectural disorganization of neocortex, and they should be coming from patients who have been determined to have focal epilepsies. There's a strong association of this with drug-resistant epilepsy. And the classification of this category of pathologies has changed several times, and I'll talk a little bit more about how that has evolved. There's a challenge in this category of inter-observer reproducibility because some of these lesions can be quite subtle. And those of you who have seen these at your microscopes definitely know what I'm talking about. So a key step in classification of these lesions came in 2004 with what was called the Palmini classification. So in this paper, there was a panel of neurologists, neuropathologists, and neuroradiologists involved, and some terms were set forth that are still maintained in the current classification. So I think it helps to review and be familiar with this. So some of the key vocabulary that came out of this paper was the existence or the kind of more clear definition of a dysmorphic neuron. These are misshapen cells. They have abnormal orientation. They have sometimes enlarged size. Their cytoskeletal structures aberrant, and they have atypical dendritic processes. The nissl substance is sometimes described as being clumpy or pushed to the margin of the cell body, and the cells are enriched for cytoplasmic neurofilaments. Balloon cells are also set forth here with some consensus that these are abnormal cells with a thin membrane, a glassy cytoplasm, and this eccentric nucleus. Or nuclei, because some can be multinucleated. And balloon cells usually are of increased size compared to your normal gametophytic astrocyte. And then they had something called the giant neuron. These are neurons of increased size, even compared with pyramidal neurons of layer 5. They should have central nuclei, but overall preserve a pyramidal morphology, meaning they're not really dysmorphic, they're just very big, and they don't express cytoplasm, they don't overexpress cytoplasmic neurofilament. So using these three cytologic descriptions, the classification was put forth and organized as follows. So we have mild malformations of cortical development, which can include type 1, which had ectopic neurons in or adjacent to layer 1, or type 2, which was microscopic neuronal heterotopia outside of layer 1 context. And then you see here how dysmorphic neurons and balloon cells are used to break apart these different focal cortical dysplasia subtypes. So type 1 was defined as lacking dysmorphic neurons and lacking balloon cells, and then could be split into type 1A or a type 1B, where the type 1B had those giant neurons that we were looking at in the last picture. But really an architectural disorganization without dysmorphic neurons or balloon cells being present. Type 2A was proposed to cover the cortical dysplasias that have dysmorphic neurons but lack balloon cells, and then type 2B for the overt balloon cell dysplasias that have both dysmorphic neurons and balloon cells present in the sample. It was also recognized in this paper that low-grade glioneuronal tumors could be associated with epilepsy, certainly was well known, but also dyslamination in the adjacent cortex. And this was discussed, but not really classified as a type of cortical dysplasia just yet. And I'm laying all this out because so much of this creates the basis for the revised classification in 2011. So it really laid the groundwork for the next iteration of classification, where a lot of these major types are retained. Type 1 is changed somewhat because it was not well established that neuropathologists could really distinguish giant neurons from dysmorphic neurons or immature neurons. So type 1 was maintained more to capture the cases of architectural disorganization, but lacking cytologic abnormality. And type 2 was basically upheld with both types A and B as previously defined. The other change is at the bottom here, which was the introduction of a formal type 3, which was meant to capture that phenomenon of lesion-associated dysplasia. So even more broad than just ganglioglioma or DNET, any other primary lesion with dysplasia associated with it would be captured in this type 3 category. So in 2011, here are the cardinal categories, and this was bolstered by results of good inter and intra-observer agreement using these categories. I maintained mild malformations of cortical development here because even though this is not as well defined, I think it still carries on being used either for lesions that are abnormal but not meeting criteria for these other types, or for that original idea of just ectopic neurons. But focal cortical dysplasia type 1 will show that architectural disorganization without the cytologic changes, and FCD2 A and B we'll look at some pictures of, and FCD3 being those architectural abnormalities in association with some other primary or principal lesion. So here's a patient with a diagnosis of mild malformation of cortical development, just to show you an example. This patient has a signal abnormality up here in the cortex. The histology in the patient showed a molecular layer that was protuberant into the leptomeninges, kind of suggesting an abnormality of cortical development, and increased neurons in the white matter and in layer 1. And so those features are not totally normal, and they do correlate to the imaging findings with this focal signal abnormality, but they don't really meet criteria per se for a type 1 or type 2 focal cortical dysplasia. To make a diagnosis of focal cortical dysplasia type 1, remember we want to see architectural abnormalities of the cortical plate without the cytologic ones. And so for this, NUN staining, again, is really so valuable. So you can see on NUN here what's termed a string of pearls or microcolumnar architecture. And in the 1B case, a total lack of lamination and some ectopic neurons down in the white matter. Moving to FCD2A, here's an example case that involves the anterior temporal lobe. And one thing I don't think we always recognize is that there's a lot of white matter abnormality in these patients. And so you can see here the white matter underlying the cortex is also looking very abnormal. And that can include increased T2 flare signal, more so seen in the white matter than even in the cortex itself. But blurring of the gray-white junction is often cited as really the key finding by MR for these patients. So when we receive this in pathology and we look at an H&E stain section of this region, similar to that FCD1B case, we see a loss of laminar organization. But to make a diagnosis of type 2 dysplasia, we want to see the cytologic abnormalities as well. And here you can see the neurons themselves are cytologically abnormal, they're maloriented, they're somewhat enlarged, in addition to being disorganized on the neuro level. So dysmorphic neurons should be large neurons. As I mentioned, they can have clumped or displaced Nissl substance towards the cell membrane, and that cytoplasmic accumulation of neurofilament that we can see well with immunohistochemistry. And here again is a value of NUN to highlight that loss of organization. In many cases, we use NUN on most, if not all, of the blocks, especially if the lesion is subtle. It can be a huge help. In a case like this, it can also show the difference in cell size between the FCD lesion and the adjacent cortex. And that can be harder to tell just on the H&E. Staining for neurofilaments is also commonly used to highlight the dysmorphic neurons, with the caveat that when you use non-phosphorylated neurofilament protein antibodies, those apparently increase normally with age, and hypertrophy of neurons alone is not really specific to epilepsy, but in conjunction with some of the other staining and even just the H&E analysis, neurofilament staining can be really. Another helpful marker is MAP2, which should highlight dysmorphic neurons as well. And it really shows that contrasting cytomorphology versus the normal sample here. MAP2 in the normal cortex should be restricted to the cortex and not really reactive in the white matter. But in focal cortical dysplasia, you're going to see that MAP2 highlights all of the areas that have abnormal. Another interesting feature of FCD type 2 is shown here. So this is called the transmantle sign. And this is considered pretty specific for a type 2 dysplasia, but it's only seen in about half of cases. So when it's present, what you see is a more extensive, but still focal in the brain overall, white matter signal abnormality, and it extends down towards the lateral ventricle. And you can see it a little bit better in the T2 images here. And here again, you see this hyperintensity from the bottom of the sulcus near the temporal fissure extending in towards the lateral ventricle. So histologically, focal cortical dysplasia type 2B is recognizable because of the presence of balloon cells. And so these are very eye-catching. They're large cells. They have ample cytoplasm. In this picture, you see a mixture actually of balloon cells, which are the paler pink staining cells, and the dysmorphic neurons that have that clumped Nissl substance, and some of it's pushed out toward the periphery of the cell. But they're about the same size, at least in this case. And so the light pink ones are the balloon cells. So balloon cells can be only sparsely present. They might be seen in clusters. They're not always evenly distributed. So doing some immunostaining to try to find them can be helpful. Vimentin staining, which I have some pictures of later, can really highlight these well in cases where they're sparse. It's not thought that the balloon cells themselves are epileptogenic. And actually, there are some studies that show that they play a role in that glutamate clearance, similar to that diagram we reviewed, where the glial cells are helping to clear glutamate away from the synapse. So it's possible that these balloon cells actually play a protective or an anti-epileptic role, actually. They do have some glial attributes. They show usually at least weak GFAP expression, but it tends to be variable. So some will be strong, and even some in the same field will be quite a bit weaker. And as I mentioned, using Vimentin to highlight these can be very useful, especially if you're having some trouble finding them or seeing them well on H&E. Sometimes they're very pale staining. And just to touch on FCD type 3 last, remember this idea was introduced to capture those cases where there's laminar changes next to another primary lesion. And in our case, on the MRI, you see this small central lesion, which was actually a ganglioglioma. And in the MR, you can see around that lesion, particularly on T2 and FLAIR, you can see there's surrounding abnormalities of the cortex with some gray-white blurring. And histologically, we have to be able to distinguish this from changes in the cortex that are due to simple tumor infiltration. So that's what this panel is illustrating here. So in panel A and panel E, we have low-grade tumors, a ganglioglioma and a DNAT, that are just invading or involving the cortex. So the ganglioglioma here is highlighted with CD34 positive cells, and the DNAT is shown with a new IHC. But that's not considered FCD. That's not a focal cortical dysplasia type 3. A focal cortical dysplasia type 3 should really show what's here in panel B, where it's not directly involved by the tumor, but it nonetheless shows an abnormal lamination. Excuse me. So I wanted to briefly mention some research that has probed the genetic basis of FCD that I think found some really interesting association. So remember that hemimegalencephaly is a more diffuse pathology that involves a whole hemisphere, but it can sometimes show similar histologic changes set to FCD. So a question arose of how these might be related to each other. And this was a series of cases that were studied that included cases of hemimegalencephaly, focal cortical dysplasia type 2A, type 2B, and focal cortical dysplasia not otherwise specified. And through sequencing studies showed that there was often gain of function or loss of function variants involving genes in the mTOR pathway. And that's a pathway, a signaling pathway in the cell that's responsible for a lot of cell functions, but influences things like cell proliferation and cell size. So the same kinds of variants were interestingly also identified in the hemimegalencephaly cases. And so the mutations themselves were seen in neurons, but also sometimes in glial cells. And then at least in this paper, there were then efforts to model these diseases in mice by activating mTOR in different developmental cell populations. But here you can see, just looking at the percent of cells that harbor the mutations of interest, that the FCD cases have a low percentage of mutated cells, and the hemimegalencephaly cases have significantly higher proportion, particularly in this neuronal population, which is shown in dark blue in the bar graph. So the two FCD cases here for whom the pathogenic mutations were only in the neurons led the authors to suggest that perhaps in those cases, the mutations arose later during development. So they didn't occur in a precursor cell that was bipotent and could become glial or neuronal, but they arose later on, and so they're only visible in the neuron. the reasoning about all of this is that if the alteration occurs early in gestation, you have a lesion that affects a larger proportion or expanse of the brain, and then an alteration occurring later in gestation might affect fewer lineages or narrower geographic area of the cortex. So their hypothesis based on this is that this is actually a spectrum of disease, which is, I think, a really fascinating idea. And a few notes on a kind of related idea, which is this entity bottom of sulcus dysplasia. So this is also associated with mTOR pathway dysregulation, and some genes in that pathway have been implicated. So perhaps another disorder in that same genetic continuum, but even more narrowly affected part of the cortex. So in bottom of sulcus dysplasia, you see maximal abnormalities at the bottom of the sulcus. So this is a pattern of focal malformation. You see the Vimentin positive balloon cells in this example are really all situated right at the bottom of the sulcus. And the PS6 staining reflects mTOR pathway activation. And you can see even by neuroimaging, sometimes this can be suggested preoperatively. And next, you might encounter or have encountered this entity MOGHE, or mild malformation of cortical development with oligodendroglial hyperplasia in epilepsy. This is a pathology that's associated with early onset frontal lobe epilepsy and imaging findings that were suspicious for FCD. But where this was first identified is among cases that had non-lesional pathology finding. So they were resected, assuming they would have FCD, and then no lesion was identified. So these were gone back to and looked at more closely and investigated. And what was found is that they often had a blurred gray-white junction and an increase in oligodendroglial cells in the subcortical white matter. And to some degree, Ki67 positivity, but that seems more present in the younger patients. So it's unclear what that really means. But MOGHE is this proposed entity, which you see in panel B, which should be distinguished from a pretty common feature in temporal lobe epilepsy, which is this oligodendroglial hyperplasia. And we sometimes see this with prominence of oligodendroglial cells around the vessels or around the neurons in epileptic cortex and subcortical white matter. This also compares MOGHE to focal cortical dysplasia, ILAE type 1, and control autopsy tissue. So there's an abundance or a hyperplasia of oligodendroglial cells in some of these cases of early onset frontal lobe epilepsy. So something to be aware of. Okay, so now we're going to show our first digital slide. So let me get out of here. And here is our first case. This, as you can see, are a few fragments of cortex with some blood, even extravasated blood in the leptomeningeal space. And let's come over here to look at this portion of the cortex because it looks slightly thickened and maybe has a nodular or scalloped surface, which looks a little bit unusual. So we'll take a close look here at what would be the cortical ribbon, and we don't really see a laminar pattern here, but we do see some very large cells. So we'll take a closer look at those. And these are dysmorphic neurons. They're enlarged, they have clumped nissal substance, and around them, occasionally we start to see some of these glassy littler cells. So let's scan around a bit more. More dysmorphic neurons. And then in here, we start to see those glassy cells a bit better. So these are very clearly balloon cells. So we have a lesion here that has balloon cells and dysmorphic neurons. They're distributed a little bit separately. Sometimes they're seen together in the same field as they are here. And then very occasionally we can see small microcalcifications in this lesion as well. So you might think about focal cortical dysplasia type 2B, which would be reasonable. But this is actually a case of, slides back up, a cortical tuber of tuberous sclerosis. And these can have overlapping histologic features with focal cortical dysplasia type 2B, as many of you know. So tuberous sclerosis is seen in about 1 in 6,000 births in the US and is an autosomal dominant disease, which involves either one of two genes, TSC1 or TSC2, which form a complex together that are part of that mTOR pathway that we've been talking about. So when you have loss of function of either of these genes, you get increased or overactivated mTOR1 signaling. And you will be familiar with tuberous sclerosis as one of these multiple manifestation neurocutaneous syndromes where you can have skin lesions like facial angiofibromas or shagreen patches, as well as some visceral manifestations, which can include rhabdomyoma of the heart or angiomyolipoma of the kidney. Cortical tubers are shown in this coronal section of the brain here as these firm whitish nodules up in the cortex where we really lose the definition of the gray-white junction. And these, interestingly, are present in TSC patients even by 20 weeks gestation, at least according to some MRI studies, which suggests that they really are coming to exist in the embryonic phase of cortical development. The other lesion, which you can see these nodules within the lateral ventricles here, which is commonly seen in tuberous sclerosis, is subependymal nodule or the subependymal giant cell astrocytoma. So here's tuberous sclerosis in a TS patient, and you can see this multifocal cortical signal abnormality in multiple lobes of the brain in this patient, as well as some signal abnormalities along the lateral ventricular surface. So those reflect the subependymal nodules, and these peripheral ones are the cortical tubers. So from the external surface of the brain, these should be quite firm. That's what gave the disease its original name, that they're tuberous. And here you can see another cut section of a tuber where we have loss of that gray-white distinction. In the bottom two panels, from low magnification microscopic evaluation, you can see on one side you have, and again enhanced by new end staining, a somewhat normal looking cortical ribbon, and on the contralateral side of the sulcus, a real lack of organization with a much broader range of distribution of the neurons, and what you start to see is maybe some very enlarged neurons as well. So closer up, this looks very similar to the whole slide image we just reviewed, but the combination of dysmorphic neurons and balloon cells, which is essentially overlapping with FCD2B pattern, is also seen in the cortical tuber. Here are more pictures of the balloon cells with a slightly different staining level of eosin on the slide, but these can be very, very numerous in some cases, can be highlighted again with GFAP. This is a dysmorphic neuron that's negative for GFAP. And then the dysmorphic neurons will show accumulation of neurofilament, just the same way as you would expect in a focal cortical dysplasia type 2. So we talked about Vimentin to highlight balloon cells, and this is just a nice example of how useful that can be. Of course, this also is going to stain astrocyte, reactive astrocytes, but you can see there are balloon cells here under the peel surface, as well as really prominently seen at the gray-white junction as well. Here are balloon cells situated within the white matter. We know that because this is a Luxol fast blue stain, so these are actually within the myelinated fibers of the white matter. And here's a nice example of a binucleated balloon cell. Okay, and then another case. So our next case is another epilepsy-associated lesion. You receive a portion of the cortex here, and we can see the cortical ribbon and the molecular layer at the superficial surface. Down in this more cauterized portion, we start to get a little bit of a clue that there's quite a lot of vascular channels in the leptomeninges, and there's some calcification or mineralization of the cortex underneath as well, some of which looks like it's associated with the small vessels. And the other side of the section, we get a little bit better look at that vascular aggregate. And it looks like these are all composed of small to medium-sized vessels, closely packed with some underlying calcification, mineralization in the cortical ribbon. So this is a case of Sturge Weber syndrome. This is also known as encephalofacial angiomatosis. It is much rarer than tuberous sclerosis, which we just discussed, but manifests with angiomas of the face, the leptomeninges, and the eye. And this is almost always sporadic. but is associated with GNAQ mutation. And leptomeningeal vascular malformations in these cases are actually not thought to arise, but to result from incomplete involution of the vasculature during development. For whatever reason, this is usually unilateral. And important to note, it can be associated with focal cortical dysplasia. So you can see dyslamination of the cortex associated with it as well. Sturge Weber syndrome on MR imaging, we'll see this leptomeningeal enhancement or signal abnormality that follows the contour of the gray matter throughout. And you can see it well on a couple of these different sequences here. And the last disease I want to touch on is Rasmussen encephalitis. This can also be a cause of focal epilepsy and sometimes can come to surgery and to pathology. So this is associated with a particular type of epilepsy called epilepsia partialis continua. That features recurring seizures with retained awareness. And some authors suggest that these recurring seizures can extend for hours, days, or maybe even years. So epilepsia partialis continua is not specific to Rasmussen encephalitis. It can also be caused by mitochondrial disorders, hyperglycemia. So it's not specific, but it's nonetheless associated. And Rasmussen is probably in the realm of autoimmune disease. It might have specific infectious triggers, but what we see in pathology is an inflammatory lesion that gradually, over the course of time, results in tissue destruction in the affected cortex. And here you see this very focal encephalitic effect on just one isolated part of the cortex. So here's a Rasmussen case we had recently that was kindly photographed by our neuropathology fellow, Dr. Jolie Sudak. And here you see the gray-white junction with quite a bit of gliosis. And there are these focal lymphocyte aggregates as well. At the higher magnification, you see the lymphocytes in association with the neurons. And by IHC, these are mixed with many microglia and macrophages, and they seem to be T-cell predominant. So at this magnification, you can see this very extensive astrogliosis reaction in the form of these schemastocytic looking astrocytes. And GFAP, here they are again. GFAP is going to highlight this intense reactive astrocytosis that can typically be found in the later stages of Rasmussen encephalitis. So we're always looking in a reactive pattern for relative uniform distribution of the astrocytes in these really beautiful long tapering processes. So this shows the relationship of the lymphocytes to the neurons themselves, and sometimes this can look like overt neuronophagia. And here's a later stage lesion, actually from the same patient. And you can see there's really destruction of the cortex, even to the formation of microcysts, which you see here through this whole part of the cortical ribbon. So there's severe loss of neurons, obviously. There's rarefaction of the parenchyma. And unlike an infarction, this is not going to correspond to a vascular territory. There's also often, as we saw, the lymphocytic aggregates or even perivascular lymphocyte cuffing, which would be uncommon in a remote infarct. So the cortical damage is shown here, and there's only really these strands of gliotic tissue in the chronic stage. And sometimes this glial reaction is really the only thing that seems to be holding the tissue together. And last today, I just want to end with a couple thoughts about tissue handling for these cases. So photography is strongly recommended for epilepsy cases, particularly if you receive the sample unblocked. We really want to help our colleagues correlate what we see to ECOG results or MRI results. And macroscopically, we might not really be able to see much, but sometimes when you go back to those photos after you look at the slides, you start to notice things that you didn't maybe notice before. This also helps us to track samples that we procure for research or banking, and including which ones might be allocated for snap freezing. So here's an example, again, from the Rasmussen's case that Jolie worked on, where she took really nice serial sections and very close photographs of these just to be able to track back after microscopic analysis. And the last thing is that we want to ensure that samples are available for potential genetic testing. Just remember, there's a growing role for genetic testing in this context. So it can be really helpful to think about this, particularly freezing tissue to optimize your nucleic acid qualities. And a few years back, we were able actually to identify PIK3CA variants in HME patients using frozen tissue that was banked up front at the time of surgery. And, for somatic mosaic diseases, sampling that affected tissue really can enable you to achieve a genetic diagnosis. And in this affected tissue, we found a variant in up to 20 or 30% of the reads. So just something to consider at the time you're triaging tissue if you think it's lesional. So here are today's learning objectives and the concepts that we reviewed. I want to thank you all for your attention, and I want to thank the AANP for the invitation to present today. These are some of my colleagues whose efforts and their pictures really comprise a lot of the material that I showed you today, and references, and I'm very happy to hear your questions. Thanks.
Yes, I think, thank you, Dr. Cotter. That was beautiful, beautiful pictures. I think we have a few minutes for some questions. I'm going to go ahead and just read some of the first question in the Q&A. This is from Mark Delvigio. Several questions about hippocampal sclerosis. How does one define gliosis only in hippocampal sclerosis? Immunostain for GFAP/Vimentin for astrocytes, or does microglial activation count?
So I would have to closely reread the literature on this, Mark, but my clinical approach to this is to do both. And that the distribution of the GFAP staining, I would say, more so drives the pattern determination for the gliosis in the hippocampus. I don't know by the letter of what's been published about this, what the kind of experts on that topic would say. So take my opinion with a grain of salt, I guess.
Okay. And then, have there been any studies of the progenitor cells in the polymorphous layer of the dentate gyrus?
Again, this is not something I know a lot about. I think these cells have been the object of some investigations. From what I understand, even Mark has been involved in some of that immunohistochemical investigation of what those cells are and what they can become. I think in the epilepsy context, we think that they are subject to alterations and even migrational changes that can occur in the context of epilepsy. So as to like closer study or characterization of those populations in the hippocampus, I would defer to others to kind of explain that in greater detail, actually.
The next question, is there any value evaluating the calbindin, calretinin, immunoreactive inhibitory interneurons that are located along the outer surface of the CA?
Can you say that again, Angelica? You were cutting out at the beginning.
Is there any value evaluating the calbindin, calretinin, immunoreactive inhibitory interneurons that are located along the outer surface of the CA?
Yeah, that's a really interesting question. I think a lot of the potential for interneuron identification, kind of looking at the distribution of interneurons in epilepsy lesions in general, is huge. But I don't think a lot of that has moved outside of the research realm, at least that I'm aware of. But I would expect maybe 10 years from now that we might be more routinely staining for specific types of neurons in some of these lesions. I think about all of the focal dysplasia cases that come in and there's no lesion by pathology. And you can see the neurons are present, but you know that something is abnormal about that part of the cortex. And if we could do more precision, cell typing, maybe we would find an answer for those patients. Maybe it's not an anatomic issue that we're going to be able to pick up by H&E, but there might be differences in the distribution of types of neurons that could be helpful to know. I think we might see that change. I don't really think, other folks can chime in, but I haven't really seen that move into diagnostic practice.
Okay, and I think it's 11 o'clock, but maybe one more quick. Does CD34 immunoreactivity offer any specific insight, and what is the pathogenesis of CD34 expression in presumably astrocytes?
Yeah, this is kind of confusing. So CD34 is sometimes called like an oncofetal protein. It's like some people think of it as a sign of like a primitive or a less differentiated cell. I think we use it in cases where we're not really sure we have a lesion. And when we see a lot of that kind of arborized cell expression, we think, okay, this looks really abnormal. But as to why it gets switched on in the cells or what it really represents, I'm not confident that we have a great answer to that question. But it is convenient when you think you have something that looks almost normal, but you have kind of iffy feelings about it. You use that stain and it just lights up everything. You say, okay, I have lesional tissue here.
And I think we're going over time, but the very last question, Matthew, how do you approach heavily fragmented specimens when you're?
Oh, with a lot of consternation, Matt. These are really challenging, and I feel like it's sort of getting worse. The way that our surgeons are operating a little bit more, a little differently in recent months. So when they're fragmented, sometimes there's just nothing you can really do. We try and feed back to the surgeons that we can't really render a very precise cortical dysplasia subtyping without good orientation of the sample. But sometimes for the patient and the situation for that specific patient, it doesn't really matter so much, actually. So that can be kind of reassuring. But yes, it is very frustrating. It happens here just the same as it happens for you. I don't have any advice for how to get a better unblocker section. I think it all has to do with sort of what's the best thing for the patient.
All right. Well, thank you, Dr. Cotter. Thank you again for joining today's AANP Teaching Rounds presentation. We would ask each attendee to take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your PATH LMS screen upon conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you have completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website in the next week. Thank you again to Dr. Cotter for an excellent presentation. This concludes the session for today. Thank you, everyone.